surfactant replacement therapy is one of the game-changing interventions that has happened in 1990s, and it is being increasingly used in the babies with respiratory distress syndrome and some other conditions. Initially, surfactant was used to endotracheal tube. After that, the concept of ensure came. Recently, we are practicing LISA and other methods. Once I speak about surfactant replacement therapy, I think Bhupendra has got a lot of work on surfactant replacement therapy. In 2020 or 2019, we first started less effective surfactant administration therapy in IPGML Calcutta. And Bhupendra is one of the investigator who was instrumental to start this design method in SSKL. And he has got a lot of work. He has done a lot of research on surfactant replacement therapy. I think Bhupendra is the right person to speak on surfactant and its various methods of administration. Without wasting much time, I request Bhupendra, please start your talk. Bhupendra, now the floor is yours.
Thank you, sir. Thank you, sir, for the kind introduction. Video, yeah, video.
The slide is visible.
Yes, sir. Yeah, video. Make a face.
Double click, please go to the slide mode.
Yes, sir. Okay. Good evening, everyone. Can I start, sir?
Yes. Floor is yours. You can start.
Yes.
Yes, sir. Yes. So the topic of discussion is surfactant administration and LISA. So coming to the overview of the topic. Today, I will discuss briefly about the introduction of surfactant replacement therapy, followed by comparison between LISA and ensure safety of LISA, evidence and recommendation regarding LISA, and beyond LISA, what are the things are beyond LISA, and finally, I will show a video how LISA is practiced. So, respiratory failure secondary to surfactant deficiency is a major cause of morbidity and mortality in preterm neonates. Exogenous surfactant therapy substantially reduces mortality and respiratory morbidity in preterm neonates. Surfactant has various functions. Surfactant reduces the surfactantion of the alveoli, increase the lung compliance, decrease the work of breathing, prevent the alveolar collapse at the end of expiration, and enhance fluid clearance. The composition of surfactant, basically, the most of the part is phosphatidylcholine. Then the second major component, neutral lipids, and there are 3 to 4 major surfactant protein like A, B, C, and D, and there are other component 2 or 3. Now, what are the various exogenous surfactant available in the market? The surfactant broadly 2 types: animal-derived or natural, and the second variety is synthetic. In synthetic, there is a 3-generation synthetic surfactant: first generation, second generation, and third generation. So, coming to the natural or animal-derived surfactant, there are broadly 2 types: mixed lung extract, and second one is the lung lavage extract. The common mixed lung extract which we used is Beractan, which is Surfactant. Second is the Poractan alpha, that is Curosur. And the common lung lavage extract which is commonly used in clinical practice is bovine lipid extract surfactant, which is the Neosurf. Another lung lavage extract is the Albuofact. The newer synthetic surfactant are that is second generation Lucinatant, and they recommend surfactant potency, that is Venticute. And the third generation is CHF, 5633. Some common brand of surfactant and their doses which we use in clinical practice. The Surfactant is 4 ml per kg, Curosurf 2.5 ml per kg, that is 200 milligram per kg, and the Neosurf 5 ml per kg. Now, what are the indication of surfactant therapy? The most common indication in neonatology is respiratory distress syndrome in preterms. And other condition, that is the secondary inactivation of surfactant, which we see in clinical practice, is meconium aspiration syndrome and pulmonary hemorrhage. Now, there is broadly three way which we used surfactant administration, or we decide to give surfactant in preterms. The first one is the prophylactic surfactant. Initially, there is a wide usage of prophylactic surfactant, but evidence does not support prophylactic surfactant. But still, in clinical practice, when the neonates is less than 26 weeks and the mother has not received antenatal steroid, or the steroid is incomplete, then and the baby is intubated in the labor room, then we used prophylactic surfactant in clinical practice. The most common way which we use surfactant is early rescue. In early rescue, after initial stabilization with non-invasive respiratory support, in initial 2 hours, if the criteria match, then we give surfactant, which one is early rescue. And in some cases, in outbound cases, when the neonates had reached to the NICU lately after 2 hours, then we used late rescue surfactant. A few words about repeat dose of surfactant. Neonates may require repeat dose of surfactant if the requirement of FiO2 is more than 40%, or the CPAP failure criteria has matched, or there is increased FiO2 requirement even in the mechanical ventilation to maintain the target saturation. Now coming to the topic proper, that is the way we give surfactant in neonates. The classical and traditional way which we give surfactant is Ensure. In Ensure, we intubate the child by using laryngoscopy, by choosing appropriate side tube. Then after intubation, we insert around 4 or 5 French tube, and we administered the surfactant in small liquid 1 ml. Then we have to give positive pressure ventilation for distribution of surfactant, and any amount of positive pressure ventilation in preterm is harmful. So the potential issue with Ensure is there is a tendency that after intubation there is a difficult with extubation of the procedure. There is a tendency to put the infant on tube, and after Ensure, there is a rapid physiological change in the lung after surfactant administration. Even a limited time of invasive mechanical ventilation may harmful for the immature lung, which can damage the alveolar capillary membrane. So the novel method which is come into practice is the lesser invasive method. Broadly, there are three types. There is the colon method, which is devised by the Cribb et al. In 2007, and they use catheter feeding tube 4 and 5 number size. And in colon method, they use the Magil forceps for the insertion of the tube. And the pre-medication, they have used atropine. Sometimes they have used atropine for the pre-medication. The second method is the Hobart method, that is known as MIST. In MIST, there is no use of Magil forceps because they have used the 16G angiocath, which is stiff and they easy to negotiate, and they have used sucrose as a pre-medication. And the Lisa method, which is in Lisa, we used 5 French feeding tube. Magil forceps is used for the insertion, and the surfactant is given in liquid in 1 to 2 minutes. And before Lisa, we give caffeine as a pre-medication, which helpful for the child, for the neonates. So what makes Lisa different? So as per the physiology is concerned, the ET tube, the outer diameter is 4.1 mm, and if we see the cross-sectional area of the glottis is 13.2. So after we put a tube, around 8.3 mm of area is occupied the ET tube. So there is only 4.9 mm of area is available for the free flow of the air. But in case of OG tube, The outer diameter of the tube is only 1.7 mm. So the area occupied is 1.8. So around 11 mm of area, cross-sectional area, is available for the flow of the air. So what is the scientific rationality of LISA? In LISA, the baby has spontaneous respiration. We use CPAP during the LISA method. We preserve the physiology of larynx and glottis function. There is no use of positive pressure ventilation in LISA. The surfactant is distributed through the flow of the CPAP and the spontaneous respirating effort of the neonates. There is a reduction of intubation trauma by using small diameter of catheter. There is a number of questions regarding LISA. What is the appropriate gestation age for LISA? What is the optimum threshold and timing for LISA? What will be the surfactant dosing? Which catheter is based? Whether sedation and analgesia should be used or not? So these are the few questions related to LISA. We will go one by one. So in clinical practice, 26 to 34 weeker units are ideal for LISA. Esteem preterm or LGAN, estimably low gestation age units are fragile. So better to practice LISA in 26 to 34 weeker units. And some mature units like 33, 34 weeker, they fight usually laryngoscopy. So some sort of sedation and analgesia may be required during the procedure. What is the optimum threshold and timing? So optimum threshold, if the child has labored breathing in the labor room, should be optimized with labor CPAP, should be transported with labor CPAP. The child should be put on non-invasive respiratory support, and early rescue surfactants should be given. And as per the European guideline, after stabilizing the neonates with CPAP, and if the FIT requirement more than 30% with 6 centimeter water, that is the indication of surfactant replacement therapy in less than 34 weaker units. So the main question, which catheter is the best? Gastric tube or stiff vascular catheter like angiocath, and some newly developed devised catheter like LISA-cath, Surfcath, and there is a new fact that is a device just like McGill forceps has been devised. So this is the question, which one is best? So in SSKM hospital, we have published a data regarding LISA, and in that observation study, around 110 neonates were studied, and the mean gestation was around 31 weeks. And in SSKM hospital, we used OG2 5 number size, and in that during the procedure, only 2 required intubation, and among 110, 11 infants required intubation within 72 hours. And we see some higher intubation rate where the neonates had higher FITO requirement before the procedure and the presence of sepsis. So the infant feeding tube is the price at 60 rupees, and where the specialized catheter like Surfcath, LISA-cath is almost cost around 2,000 to 3,000 rupees. So LISA is feasible and safe to administer via a orotrachally introduced 5 pins infant feeding tube. So the next very important question, what will the length? How much we have to insert the tube into the vocal cord? So as per the different study, they have given that the tube should be inserted 1 to 2 centimeter beyond the vocal cord. And as per our RCT, which we published in 2020 in European Journal of Pediatrics, we did a RCT in 28 to 34 weeker neonates with RDS, and we devised a formula that tip to lip length was calculated based upon our some observation study, based upon some X-ray finding, that the size, the length should be 7 centimeter plus weight of the neonates in kg, because the length is very important for uniform distribution in both the lungs. Now, which surfactant is best and what would be the groups? And as per the European guideline on RDS, they have recommended Curosur with the better option because the amount, the volume is less, 2.5 ml per kg. Because in LISA, there is a tendency of reflux. So if the amount of surfactant is less, then the amount of reflux will be less. So they have given recommendation the Curosur is better for LISA. But some study has shown that there is no statistical difference between Curosur and Surfactant. There is a financial constraint regarding Protectin alpha, that is Curocell, because Curocell is costlier among all the surfactant. Then the next question, use of pre-medication, whether to use or not. Till date, there is no consensus concerning pre-medication prior to DIJA procedure. They have studied various medications like propofol, ketamine, atropine, morphine, lidocaine, fentanyl, but there is no concrete evidence to support or refute any pre-medication. But non-pharmacological measures like swaddling and giving sucrose and giving breast milk is advisable, and giving surfactant before LISA is a very important intervention for the successful LISA procedure. Now, again, in SSKM, we have published there's a RCT regarding the pre-medication. So in that case, we study giving fentanyl 1 microgram per kg over 2 to 3 minutes just
क्या
before,
हुआ? हाँ क्यों?
2 to 3 minutes before, just before the LIJA procedure. And in our study, we got the revised preterm pain profile score during the LIJA was significantly lower in the fentanyl group. But there was no difference in short and long-term outcome measures. Now the question is whether LIJA is safe procedure, because LIJA depends upon the skill. The most critical event is insertion of the catheter, because laryngoscopy we have mastering of laryngoscopy, but how the catheter tips should be inside the vocal cord, because the outcome of the intervention depend upon the tip of the catheter and the length. So mastery of the skill in inserting the OG tube, the most important thing. There is some amount of surfactant reflux in LISA, around 10 to 50% of surfactant get reflux. There is an episode of coughing and gagging. Acute dissociation is the most common event. The different studies have given different data, but it is the most common finding which we see during the LIJA procedure. There is a bradycardia also, in the tune of 20 to 30%, there is a occurrence of bradycardia. And in some sort of 10 to 15%, neonates also required positive pressure ventilation during the procedure. And LIJA is not a single intervention, it is a complex care bundle. The success of the LIJA depend upon both antenatal, labor room, the transport, and the NICU care. All that matters for the successful outcome of the LIJA. So giving antenatal steroid in the ideal candidates, right timing of delivery room CPAP in the delivery room CPAP, then giving delayed cord clamping in the OT tables, avoiding hypothermia, avoiding unnecessary manipulation, and giving caffeine before the procedure of LIJA help for the better outcomes. Now, what are the evidence regarding LIJA? There are around 20 RCTs and 4 systemic review and meta-analysis related to LIJA. So into 2021, there is a Cochrane review. That review has studied 16 RCT, and the composite outcome of that and BPD, the risk reduction was 0.52. Isolated BPD, the risk reduction was 0.57. Mortality was 0.60. And the need of mechanical ventilation within 72 hours was 0.62. So evidence support LIJA. Now, regarding the safety, now there is Optimist A trial, which has the study population was 25 to 28 weeker, and the use of LIJA did not appear to be any harmful intervention. It was associated with lower risk of BPD. Then the 2-year outcome after Optimist study, in the mixed group had lower rates of adverse respiratory outcome during the first 2 years of life, but there was no impact on neurodevelopmental outcome at 2 years of age. Now, there are some recommendations. As per the Indian guidelines, NNF recommend LIJA may be the favored over insured for surfactant delivery in preterm neonates with RDS who are less than 34-week gestation. And as per the European consensus is concerned, they have stated that LIJA is the preferred method of administering surfactant to spontaneously breathing baby who are on CPAP. Now, there are some questions which are unanswered in LISA because LISA still is an invasive procedure. It needs laryngoscopy, it needs insertion of the tube. So, uh, LISA is still, we say it is less invasive, but still there is some procedure are invasive in LISA. Again, during the procedure, we insert the baby is put on CPAP, and during the procedure, the CPAP transmission is hampered. So there may be some episode of hypoxia during the LISA. And the LISA catheter occupy 50% the airway in extremely low gestation age neonates. And the most important, there are no reliable method of confirming the placement of thin catheter into the airway. There is no reliable method. It all depends upon the doctor or resident doctor who is putting the tube inside the vocal cord, who knows where the tube is. So because the success of the LISA depends upon the tip of the tube. And what about beyond LISA? Because LISA is invasive, so less invasive, but still there is some intervention are invasive. So there is a NIST. NIST is nebulized surfactant therapy, and it has been there is a parallel double-blinded randomized controlled trial. We have seen that nebulized surfactant therapy in preterm infants in mild RDS, they have studied with bubble CPAP, and in second arm, they without CPAP and aerolized oractin alpha. And in the study, they have seen there is a reduced requirement of intubation in higher gestation age. Someone please unmute the mic.
Mohammad Abu, please mute your mic. Mohammad Abu, please mute your mic.
Till the mic is on. Yes, okay. Sorry for the interruption. Another modality of surfactant administration is the laryngeal mask airway. There is a randomized trial of laryngeal mask airway versus endotracheal intubation for surfactant therapy. In that RCT, they have seen that in a higher gestation age, this is a feasibility study. They have seen that it is feasible to administer surfactant in via LMA, and compared with the surfactant given via ET tube, they achieve better oxygenation and lower need of invasive mechanical ventilation. There is another study going on pharyngeal administration, that is POPART study, and study suggested benefit in less than 25-weeker neonates for smoother transition and reduced intubation needs. POPART trial is currently underway investigating the efficacy of delivery room pharyngeal surfactant administration in infant with gestation age of 28 weeks or less. Now coming to the procedure, the proper LISA procedure. So this is a neonate. If we do a proper classical mask with midline interface, the child is having grunting, there's an increased work of breathing. So we selected the child for surfactant administration. So these are the instruments which we required for LISA procedure. This is a McGill forceps, laryngoscope as per the gestation age and weight. This is the pre-filled surfactant in the syringe and one OG tube. Before giving surfactant via LISA, we have to change the interface because the classical midline interface with the mask is not suitable for laryngoscopy because the field will be obscure. So we have to change the interface, either the OptiFlow or the Ramanathan cannula. And through that cannula, the CPAP will be continued. This is a video showing LISA method. So these are the instrument. which we prepared before doing the Lisa procedure. We need assistant during the Lisa procedure. So I'm holding the McGill forceps. I'm holding the OG tube through the McGill forceps and giving the tube to my assistant. Now I am going to do the laryngoscopy. The child is already on interface and NIPPV.
Hello. Hello. Hello.
Now I'm doing the laryngoscopy. I'm visualizing the vocal cord. Now, with the help of McGill forceps, I'm inserting the OG tube inside the vocal cord.
আমার সব করা হয়ে গেছে। আমি গাধা তো, তাই গাধার কাজগুলো আমি ভালো করি, বুদ্ধিমান কাজ ভালো না করতে পারি।
So I've already inserted the tube inside the vocal cord. Now I'm seeing taking the length. Surfactant is given to the syringe in 1 ml liquid by the assistant. And during the procedure, we have to monitor the heart rate and saturation for any acute deterioration. The surfactant is given in a liquid of 1 ml at a interval of 1 minute, around 30 seconds to 60 seconds. And as you see, there is some amount of reflux of surfactant, and the reflux of surfactant also indicated that the catheter has gone to vocal cord, because only when the catheter is inside the vocal cord, there will be some amount of reflux. So there is some amount of reflux also. And after the surfactant has been administered, we have to change the interface from the OptiFlow or the Ramanathan Kanura to proper midline interface, the standard interface for proper ventilation. So what we have done in the procedure, we have put the child on a non-basic positive pressure ventilation, but the interface has been changed to Ramanathan Kanula or OptiFlow for the better visualization. Then a 5 feeding tube has been inserted to the desired depth as per the weight. And once the feeding tube was correctly positioned, Puractin alpha, that is Curosol, was administered at a dose of 200 mg per kg into the trachea in 1 ml liquid. And after surfactant administration, the feeding tube was removed, and the interface was switched back to nasal tubing and nasal mask for an IPPB or CPAP. So coming to the take-home message, Lisa is the preferred mode of surfactant delivery, because as Bijan sir say always, the less is more in neonatology. The less we do, the better is the outcome. And the second point is expertise. So we need some sort of expertise and for the insertion of the tube inside the vocal cord. And there's a large variability in the method of Lisa, because there's a newer device has been device has come to the market, like Lija Cath. So it all depends upon the resident doctor, how they are expert in the method. And in still the future, there is a quest to identify the best minimal invasive method of surfactant administration has to be identified for the better outcome in preterm units. Thank you.
Thank you, Dr. Bhupendra, for nice deliberation. Please. Now I request Dr. Bijon, please sum up and take up the questions which are in the chat box. Dr. Bijon. Till Bijon is coming, one chat box question is the.
I have seen, sir. I have seen, sir.
Okay.
So I think most of you are actually doing Insure, but over the years, Lisa has become one of the standard of care and surfactant administration therapy. Second important thing is that what Bhupendra has highlighted, Lisa needs certain kind of expertise, and also needs a Lisa catheter or feeding tube. He has rightly said, oh, in the last 5 years, we have performed more than 500 infants with Lisa procedure, and our study says that our failure rate is around 10%. Second important thing is that whatever method you use, it should be done in all aseptic and antiseptic care. Thirdly, if you want to administer surfactant, always use human surfactant, not animal-based. There are animal-based surfactant not human, it's animal-based surfactant, not synthetic surfactant. There are 2 or 3 preparations are available in the market. One is Surfactant, that is Surfactant. Second is Curosarb, that is Surfactant. And third is Neosarb, that is Surfactant. And if you see the difference between these surfactants, there is not much difference. Although Bhupendra said most of the procedure in our unit we have done with Curosarb, but in the last 2 studies, he has not highlighted those studies. One study was performed comparing Belactin versus Coractin in babies for Lisa's administration. There we found there is not much difference, no statistically significant difference between Belactin and Coractin. Recently, we have conducted another trial comparing Neosarb versus Curosarb. Here also, we didn't find any significant difference between Neosarb or Curosarb in Lisa. So whatever surfactants are available with you, you can use them. But one advantage of Curosarb is that the volume will be low, the regurgitation will be less. But although we have done studies mostly above 28 weeks of gestation, but in our experience, less than 28 weeks of gestation with Baractan or Coractin is not much. So just I want to know from all of you, how many of you are practicing Lisa? Please write in the chat box either yes or no. So you can write. Before you write, let us discuss one question. During Lisa procedure, you lock the McGill forceps at a specific marking of the feeding tube. How to calculate that? Bhupendra.
Yes, sir. Actually, just the length will be the tip to lip length will be the weight of the baby plus 7 centimeter. I'm just holding the tube with the McGill forceps at the length of 4 to 5 centimeter just to stabilize the catheter. There is no specific point. Just for stabilization, we have holding the tube at 4 to 5 centimeter, but the insertion depth will be weight of the baby plus 7 centimeter. That means the distal end of the tube should be at the upper lip at the length will be calculated based upon the weight of the baby. The baby weight is 1, then the tube will be fixed at upper lip at 8 centimeter.
So what Bhupendra has said, you hold the catheter around 5 to 6 centimeter, because most of the time it will be more than 7 centimeter. 7 centimeter plus weight in kg. So at least 7 centimeters. So what he's saying, that you hold the catheter around 5 to 6 centimeter just to stabilize the catheter. Then you just introduce the catheter till is the measured length has been introduced. And after that, you give surfactant in any cut over a period of 1 to 3 minutes. And initially, we were using Megal forceps, but nowadays our recipients are doing without Megal forceps. So, as a beginner, when you start, you use Megal forceps. But over the years, we have got a little bit of experience on laser procedure. So nowadays, our recipients are not using actually Megal forceps. They are not without Megal forceps. They are doing. So it depends on the experience how you can do. So second question was, how much does Curosap cost? 200 milligram Curosap cost will have around 18,000 or 90,000. Sir, I have done laser during PG sheet, but without Megal forceps. Okay, good. Dose of nebulized surfactant is also 200 milligram per kg.
The nebulized surfactant therapy is in very initial state. They have used DPCC, palmitic cholic acid, DPPC surfactant they have used for nebulization. The study has not done with Curosol. So the exact dose I have not remembered. I have to cross check. But whatever I remembered in nebulization, they have used DPPC as a surfactant. That is first generation or second generation synthetic surfactant for nebulization. But I have to cross check the dose.
Another important problem is the nebulized surfactant, because if you know, when you give nebulized drug, only 5 to 10% of the drug actually goes inside the lung, alveoli. So it is in the experimental stage. We have to wait for the further trials. Next question. So although, and another important point to remember, Curosap has got two doses regime. One is 100 milligram per kg bottle and second is 200 milligram per kg. And most of the our studies, all the studies, we have used 200 milligram per kg per day, per dose in all the studies. But there is no comparison between 100 milligram versus 200 milligram. But I mean, whatever surfactant you have, you can use that surfactant for laser procedure or inch. Any more question? So after what time should we repeat X-ray? If there is suboptimal response, how many times can we administer surfactant? Subhadev is asking.
Suboptimal response of surfactant classically seen if the baby is having birth asphyxia or the baby is having hemorrhaging unstable or sometimes sepsis. So if the response is suboptimal, then we have to first to see whether there is some coexisting disease process associated or not, birth asphyxia or sepsis or hemorrhaging instability. And even after giving surfactant, if the response is not suboptimal, then we can give the surfactant after 6 hours. Regarding X-ray, I think clinical judgment is better than the X-ray because for surfactant therapy, X-ray is not mandatory. We have to clinically assess the site and the units, and the minimum interval for second dose will be around 6 hours, minimum 6 hours. We can repeat the dose, but we have to identify why the baby has not responded.
So what Bhupendra is saying, that if you want to give second dose surfactant based on the actually FiO2 requirement, suppose your FiO2 requirement is still more than 30% or 40%, then you give the second dose of surfactant after 6 hours. Sometimes there is some manufacturer's recommendation. You can follow the manufacturer's recommendation. Some manufacturers recommend after 12 hours. One important thing he has highlighted, whether the baby will respond to your surfactant administration therapy or not, that will depend on the initial stabilization of the baby in the delivery room. Suppose you have done a lot of bagging, there is some release of inflammatory exudates, you have got some trauma to the alveoli. Time even if you surfactant, that will not the optimal response you may not. That what happens mainly in case of sepsis, asphyxia, etc. So it is better to stabilize the baby in the delivery room without causing damage to the alveoli. If you damage the alveoli, the recycling mechanism of the surfactant will be lost. In that case, you may not get the optimum response. Traditionally, once you give surfactant, immediately there should be response. There should be improvement in the compliance and the resistance of the lung, and there will be better gas exchange. So you will find better saturation. If you do not find better gas exchange, better saturation, or increased work of breathing, that means something is wrong. Whether your diagnosis is wrong or there are some already damage to the baby's alveoli. This can happen mostly in the late rescue surfactant therapy, because late rescue surfactant therapy is usually given after 2 hours, sometimes about days also, because most of the babies will be from outborn infants. The outborn infant, during this time, there will be a lot of damage to the alveoli. So, one important message is that actually, if you want to improve the neonatal outcome because of this respiratory morbidity RDS, your delivery room care should be optimal. Second important is antenatal corticosteroid. So, if the antenatal corticosteroid sometimes suboptimal doses are there. Another important thing, if you give antenatal corticosteroid, many babies will not have RDS. I think that answers your questions. And routinely X-ray is not done, because when you are giving surfactant, that time also you did not go for X-ray. But X-ray is done for a diagnosis, or if you think there is some deterioration like pneumothorax, etc. Another important thing is that once you administer surfactant, there will be compliance of the lung. So we have to do like PEEP, because that manual reduction of PEEP is very, very critical. And you have to do that. Means after administering surfactant, you have to see the baby's response. You have to clinically assess the baby's Silverman score or Downey score. And there will be immediate improvement. Once there is improvement, based on the baby's work of breathing and the saturation, you titrate your bed-sitting and expiratory pressure or CPAP pressure. Now, Bhupendra sir is asking, how to insert without making forceps. Sir, it depends on the expertise actually. Once you start doing, actually, I always feel what we have seen before administering surfactant by Lisa, at least 10 or 15 Lisa procedures should be seen by the resident. Once they have seen 10 or 15 procedures, and after that, they should do first Lisa in front of some other, under some supervision. Then only you can start, otherwise there will be some problem. I still remember the Lisa, what Bhupendra has already highlighted. Once, when we started Lisa technique in SSKM hospital, I gave a thesis to Bhupendra. And after 4 months, he came to me, sir, you changed my topic. Why? I am not able to perform this procedure. But he has really worked hard to perform the procedure, and whatever the link technique, that method, what you have seen, that we call actually Bhupendra's method. He has actually, by observation and by doing some X-ray, he has seen that the catheter, the whole of the feeding tube catheter is just 1 centimeter above that what is there in the endotracheal tube. That is why he has made the calculation weight in kg plus 7 centimeter. In conventional lip to tip distance in endotracheal tube is weight in kg plus 6 centimeter, because the opening of the feeding tube is at least 1 centimeter above the what is there in the ET tube. So that is his innovation, and we are practicing it, and we are successful. So if we give Neosub to a baby and there is suboptimal response, can we repeat surfactant with a different brand or type if the first type is out of stock? If there is out of stock, definitely you can. But the cost of Neosub will be lesser than. Any more question? How long should we wait to give surfactant after putting the baby on CPAP?
So after stabilizing the baby on CPAP or an IPPP, we have to decide within first 2 hours of life. If the after optimum setting and if the interface is working good, there is no leakage, and the child factor requirement is more than 30%, and the neonate is not achieving the target SPO2, then the first 2 hours you have to decide. If the criteria has matched, the CPAP is working properly, a factor requirement is more than 30%, child is less than 34 weeks, give surfactant first 2 hours within.
So, and what Bhupendra is telling, early rescue is better than the late rescue suppression. So, whatever you have to do within 1 hour or within 2 hours. So, most of the time, if you give CPAP and the baby is maintaining saturation, there is no increase of output breathing cells. If I is less than 30%, you don't find any bad type of accident, then you can wait. But if the requirement of FIO is more than 30% and baby is retracting and everything is in place, as he has rightly said, once you escalate the support or give some new thing, new addition, then you have to see whatever support you have given, whether it is working or not. Like your interface, there will be leak. So if there is leak in the interface, they will not get anything. So you should make sure that whatever intervention you have started, that is working well. If everything is fulfilled, despite that baby is desaturating and we increase work of breathing and if I have to recover more than 30%, go ahead. Any more question?
How many times can surfactant be given for the same baby? What is the maximum time within which we can give surfactant?
Bhupendra, what is how many times can give surfactant for the same baby? What is the maximum time?
As per guideline is concerned, the maximum
Please.
time is 3 times. But if the baby is requiring 3 times, definitely there is some other problem. The baby is not having some coexisting problem must be there. But the maximum times which we can give is 3 times.
So what is saying maximum you can give 3 times. But what we have observed and what is our experience, if your baby is not responding the first dose, you can give second dose after 6 hours. If the FI2 requirement is 40%, even after giving the second dose, baby is not responding, there is hardly any chance that baby will respond to third or subsequent doses. So that will wastage of time, wastage of resources. So give first dose, do the things appropriately. And another important thing is sepsis. If the baby is a coexistent sepsis, surfactant response may not be there. Because the same thing will happen that will ultimately exudate, that will hamper the recycling mechanisms of surfactant at least. Any more question?
No.
If you can unmute yourself, you can ask directly questions to Bhupendra.
Please now unmute if any question, if you can ask to our speaker, Dr. Bhupendra Gupta. But please listen one thing. But please listen one thing. During our speaker's lecture, please mute your mic audio. Otherwise, it is very difficult for the speaker to continue the lecture and the other participants to hear his lecture. So I am requesting you all, please mute during when the speaker will deliver his lectures. Then continue.
So before we wind up, some of the important things you should keep in mind. Every baby has to be attended by the healthcare staff at the delivery room. Good resuscitation is the key. Antenatal coagulative steroid is a game changer. Bring the baby, start early CPAP. It has been seen even without surfactant, many baby can be managed. So when you do not have the facility for administering surfactant, you can actually manage the baby with CPAP. Third important thing is that if you want to give surfactant within first 2 hours of life, that is early rescue surfactant. It is whether you give Lisa or Ensure, it does not, whatever procedure you are comfortable, go ahead with that technique, because Lisa needs certain expertise. If you do not have the expertise, do not go for Lisa. It may create some problem. You can do Insure also. There is no problem. Lisa has got a little bit of advantage over Insure because it is little bit non-invasive, and various studies have shown, and our experience is also showing that after Lisa, our actually failure rate has come down, and also the hospital stay is also less. So, sir, can Lisa be done in case of cleft lip or palate? Bhupendra, this is an interesting question. Whether we can do Lisa when doing having cleft lip or cleft palate.
I think cleft lip will be no issue because there is no problem in intubation. Cleft palate,
No.
there may be some problem because cleft palate is a cases where the intubation is difficult. So personally, I have no experience on cleft palate and cleft lip, but theoretically, cleft palate, I think Lisa will be little difficult. Cleft lip, I think it is feasible. But personally, I have never experienced
Yeah.
cases in my clinical experience.
See, you are right. It is because in Lisa technique we are using CPAP, and you are giving surfactant at the same time baby is getting CPAP. But if there is cleft lip or cleft palate, you are right that this is one of the contraindication for CPAP therapy. But there will be some issues. We have not tried on the babies with cleft lip or cleft palate. Third question is that is X-ray or USG mandatory before giving surfactant?
Big no, big no.
Big no. Because it is the FiO2 which is important. You don't have to go for X-ray or USG. If you have got the facility, you can do. Another important point to remember, if you give surfactant therapy, you should have backup facility for ventilation because some babies may require respiratory support with mechanical ventilator. If you do not have the support of mechanical ventilator, at least nearby you have the facility and you have got the tie-up with that hospital. Because some infants may require mechanical ventilation after surfactant replacement therapy, whether it is Lisa or Insure. So for that, one is whether you give Lisa or Insure, you need a CPAP machine. But if some babies fail in CPAP, then you have to go for mechanical ventilation. So you should have backup facility for mechanical ventilator with you, or if it is not available, at least some nearby hospital where you have got the time. So, as a maximum 6 hours, yes, maximum 6 hours can Lisa be done. Is accessory mandatory. So, if there is no more question, okay. Thank you very much. So, thank you very much. If there is no more question, we can wind up the session.
Thank you. As there is no question, so we can wind up the session.
We can wind up the session. If you have got any question, you can write in our group. Our speakers will be happy to answer. Thank you very much. Good night, everyone. Thank you.
Good night. Good night. Good night, Bijon and others. Good night. Good night, Dr. Bhupendra. Good night.
Good night, sir.
Thank you.
Good night, Bhupendra.